Hi everyone, my name is Anna Goodman, and today I will be presenting about imaging consciousness and perception. So here are the different topics we will be covering today. You can glance over these and come back to this point at the end of the presentation to check your understanding. We're going to start by trying to define what consciousness really means. So the clinical definition of normal human consciousness is the presence of a wakeful arousal state and the awareness and motivation to respond to self and/or environmental events. The three main components being arousal, awareness, and motivation. Arousal is the overall level of responsiveness to environmental stimuli. It can range from stage 3 non-REM sleep, where a strong stimulus is required to elicit a response, to states of high vigilance where a subtle stimulus can be detected and acted upon. Arousal is simply a global state of responsiveness. Awareness is the brain's ability to perceive specific environmental stimuli in different domains. This could be visual, somatosensory, auditory, and interoceptive. And lastly, motivation is the drive to act upon internal or external stimuli that have entered conscious awareness. Now, the problem with this clinical definition of consciousness is that it can entirely ignore covert consciousness. Covert consciousness is the presence of subjective experience in the absence of behavioral response. More recent neuroscience has described consciousness as including volition, processing of sensory information, and a generalized level of arousal to account for covert consciousness. Now, this brings us to the hard problem of consciousness. The hard problem is the question of how and why physical processes in the brain give rise to subjective experience, and explaining why any physical state is conscious rather than non-conscious. Because the hard problem is exactly what it says, hard, most neuroscientists choose to set it aside. Instead of explaining the existence of consciousness in the biological world, they choose to explain generic consciousness by identifying neural properties that can turn consciousness on and off, and explain specific consciousness by identifying the neural basis consciousness, called neural correlates of consciousness, or NCCs. NCCs are the minimal set of neuronal events and mechanisms jointly sufficient for a specific conscious perception. Many studies have shown that consciousness is supported by the interrelation of a few different networks, including the ascending reticular activating system in the brainstem, the nonspecific nuclei of the thalamus, and the widespread thalamocortical projections to anterior cingulate, posteromedial cortex, and frontoparietal association cortices. Neuroimaging tends to reveal more about consciousness than we originally thought. In patients with pathological disorders of consciousness, covert consciousness can occur without any overt behavioral signs by standard clinical assessment. Therefore, a reproducible brain signature of consciousness, completely independent of behavior, would greatly enhance its accurate determination. When using neuroimaging to understand consciousness, often a multimodal approach is the best way to go about it. Multimodal imaging means that you are imaging a subject with two or more modalities, while the images are being registered in both space and time. Commonly, this could be any combination of fMRI, EEG, and PET scans. fMRI is a non-invasive brain imaging technique that measures brain activity by detecting changes in blood flow, often utilizing the BOLD signal. Although detailed, it requires the patient to be very still and is often very costly. EEG is an imaging technique that measures electrical activity of the brain using placed electrodes on the scalp. It is usually cheaper than fMRI, but the results are not as precise. PET is an imaging technique that can help reveal the metabolical or biochemical function of your tissues and organs. Now, there have been many different studies regarding neuroimaging and consciousness, but for now, we will just focus on studies involving disorders of consciousness. A disorder of consciousness is defined as a medical condition occurring when brain damage affects consciousness. This could be anything like vegetative state, coma, minimally conscious state, and others. A significant addition to this field was the development of fMRI paradigms that make awareness reportable in patients who are entirely behaviorally non-responsive, and therefore diagnosed as vegetative. This utilizes the principle that imagining performing a task generates a significant pattern of brain activity that is similar to actually performing the activity itself. In a study done by Bowley in 2007, 34 healthy volunteers were asked to imagine hitting a tennis ball back and forth to an imaginary coach when they heard the word tennis, and to imagine walking from room to room in their house when they heard the word house. Imagining playing tennis was associated with robust activity in the supplementary motor area in all the participants scanned. In contrast, imagining moving from room to room in a house activated the parahippocampal cortices, the posterior parietal lobe, and the lateral premotor cortices, all regions contributing to spatial navigation. Owen, in 2006 and 2007, used the same logic to demonstrate that a patient diagnosed vegetative state was, in fact, consciously aware and able to make responses of this sort using her brain activity. The patient was instructed to perform the same two mental imagery tasks as the earlier study. When she was asked to imagine playing tennis, activity was observed repeatedly in the supplementary motor area, and when she was asked to imagine walking through her home, significant activity was observed in the parahippocampal gyrus, the posterior parietal cortex, and the lateral premotor cortex, all activity mirroring that in the healthy individuals. It was concluded that despite being diagnosed vegetative state, this patient retained the ability to understand spoken commands and to respond to them through her brain activity, rather than through speech or movement, confirming without a doubt that she was consciously aware of herself and her surroundings. An fMRI mental imagery paradigm can demonstrate consciousness when behaviorally an individual is non-responsive. Although many studies test individuals with disorders of consciousness, there have been a few studies that have attempted to simulate a lack of consciousness in healthy individuals by administering anesthesia, thus creating a reproducible model. Testing the hypothesis of covert consciousness with anesthetic drugs offers the possibility of within-subject design, meaning the same subject can be evaluated during the task at precisely controlled levels of consciousness that are induced by drug dosing. Huang in 2018 had 5 healthy volunteers use 3 imagery paradigms: tennis, navigation, and a squeeze imagery task where volunteers were instructed to imagine squeezing a rubber ball. While administering a stepwise propofol infusion, the volunteers' grip force was observed to evaluate overt responsiveness, while an fMRI monitored covert consciousness and brain activity. Although 4 of the 5 volunteers' results were not significant, one volunteer showed that mental imagery and motor response tasks had significant patterns of activation in specific regions of the brain, both when the subject could overtly respond as well as during a loss of response as well. This study demonstrates the possibility of using anesthetics to test methods assessing covert consciousness in behaviorally non-responsive patients. Although neuroimaging provides some exciting direction and promise in the realm of consciousness, there are still some challenges it needs to face. One challenge being that common brain signatures of covert cognition in patients with differing neurological injuries can be limited by inter-individual variability, meaning every person is different, so signs of their cognition could differ as well, especially following injury. Another challenge is that in studies comparing to healthy individuals, functional areas mediating imagery tasks may be different in the patients studied as opposed to their healthy controls. Another challenge could be that many vegetative state patients have structural abnormalities including or close to the imagery task-related regions, so these abnormalities could interfere with the accuracy of the regions being studied following these mental tasks. The next challenge is that it hasn't been settled whether structural damage is a necessary condition for the dissociation between covert consciousness and overt responsiveness. And finally, the possibility of using fMRI or EEG for the detection of awareness in behaviorally non-responsive patients raises a number of issues for legal decision-making relating to the prolongation of life after a severe brain injury due to the presence of consciousness. So, in conclusion, consciousness is very complex. With the help of neuroimaging, we can dig a little deeper into consciousness and obtain a better understanding of what consciousness truly entails. And here are my references. Thank you.